Again, thank you. Just acknowledging I'm coming from Stamanis First Nations on beautiful Vancouver Island in the town and near the town of Ladysmith. Sorry about that. And to let you know who I am, I'm Jennifer Jones. I'm a member of Liaxin First Nation. I've worked in as a community health nurse in various management positions for the past 21 years within a couple of communities. So currently I'm the health manager for Stamanis First Nations, and I serve one of 3 regional board representatives on Vancouver Island, representing the Coast Salish family. So today I just would like to welcome Warren Claremont and Ashley Turner from the BC Cancer team, as well as Kyla Sorrento from FNHA. As our meeting increases on platforms such as Zoom over the past 2 years, many of us are experiencing meeting fatigue. As health directors, we need to remind ourselves of the importance of self-care, maintaining our own wellness as we model healthy choices for others is a priority. And we know that staying motivated on the journey to wellness can be challenging. However, I'm very excited to learn from the BC Indigenous Cancers overview and update on the following topics. New Indigenous patient navigator at the cancer centers, cancer surveillance and data linkages projects for First Nations, screening programs overview, breast, collateral, cervical, and lung cancer, outreach, education, and awareness to support our First Nations communities, cancer resources, and supports for First Nations. At this time, I'd like to turn the meeting over to Warren and Ashley. Thank you very much.
Great, thank you so much for that, Jennifer. And I'm just going to share a screen here first. Okay, great. Well, thank you for joining us today. And for those who might be watching this later as it's recorded, we appreciate you taking the time to join us. Just going to introduce ourselves first before we get into the presentation. So my name is Warren Claremont. I'm the Provincial Director of Indigenous Cancer Control here at BC Cancer. I'm originally from the Hazeltons up in the northwest central part of BC. My mother is from the Gitxsan First Nation, and we're all members of the Gitmax band through her. And my father is French and Ukrainian. And I've been down here in Lekwungen people's unceded and traditional territories for the past 23 years. And they're known as the Songhees and Esquimalt First Nations here in the West. Of course, we have nations throughout the island, Ostanik peoples, other First Nations from the Chalmette and the Kwakwaka'wakw peoples. So just really happy to be here today and living in those lands. And yeah, I'll pass it on to my manager, Ashley, now to introduce herself.
Thank you. Hello, everyone. Tanshi. I'm Ashley Turner. I'm the manager with the Indigenous Cancer Control Program with Warren. I'm a proud Métis citizen on my mother's side. I'm English and Scottish on my father's side, and I live in beautiful East Vancouver, so the unceded and ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh. Excited to be here. Have a good day, everyone.
Maybe Kayla, do you want to introduce yourself first before we get started?
Yeah, that's great. Thanks, Warren. Good morning, everybody. Thanks so much for having me. My name is Kayla Sorrento, and I'm a senior policy analyst working with the First Nations Health Authority. I'm of mixed European heritage, Romanian and Scottish ancestry, and I grew up in Silks territory, and I've been really grateful to be able to live in Squamish, Tsleil-Waututh, and Musqueam territories for the past 20 years and have the opportunity to raise my little one here. So thanks for having me, and I look forward to being able to share a bit about some existing resources within the FNHA that might be helpful.
Great, thank you, Kayla. And I did forget to mention, it's been so long now, 12 years, that I'm also a cancer survivor. I was treated here at BC Cancer Victoria in 2009 for the better part of a year. Now working alongside many of the care providers who treated me back then. So it's come full circle, and I feel I've been put on this path to do this work. And so I'm just grateful and humbled to be able to be in this position. So let's begin our presentation. First slide here. I mean, I can change the slides here. There we go. So how is cancer care delivered in BC? Well, BC Cancer, we're part of the Provincial Health Services Authority, so one of the 6 health authorities, but not a regional health authority. We have 6 standalone cancer centers across BC, and that'll be Victoria, Vancouver, Surrey, Abbotsford, Kelowna, and Prince George, with more centers potentially on the way and being planned to be built. And so they provide systemic therapy, also known as chemotherapy, radiation therapy, diagnostics, and we manage the screening programs as well. As I mentioned, part of the PHSA, the Provincial Health Services Authority, responsible for specialized health services across the province. We have about 25,000, I want to say, employees in PHSA, and about 3,500 of them work at BC Cancer. So we work with the 5 regional health authorities, as I mentioned, in delivering the screening programs and managing them. Also, chemotherapy and health authorities deliver surgeries. The health authorities also manage 42 what we call community oncology network locations. So these will be in partnerships with the health authorities, primarily in hospital settings where you can receive different types of cancer treatment, usually chemotherapy, screening, surgeries, of course. And so we have 42 of those locations across BC. And so those locations, we kind of categorize them in tiers. So it's like tiers of service, with tier 6 being the highest and tier 1 being the lowest. Tier 1 are kind of your community clinics where you might be able to get oral medications, oral chemotherapy, but they wouldn't have an oncologist on staff, and it would be your basic cancer services. Tier 6 being the highest in Vancouver. So our biggest cancer center has the most specialized diagnostic equipment and staffing, and so that'll be our highest tier in Vancouver. So the health authorities, as I mentioned, administer about half of chemotherapy in BC. They deliver the screening and implement the screening programs, and we manage them. And of course, they deliver all the surgeries. All right. So the screening programs, we manage 4 screening programs at BC Cancer. And while there are numerous cancers and other ways to screen for cancer, these are the 4 main programs that we manage. And so the first is cervical screening. These, you can see the guidelines. I included the links here. Obviously, through each of these programs, you want to talk to your care provider. Any of our colleagues will tell you talk to your care provider because everybody's situation is different. So these are guidelines, but that being said, cervical screenings recommended currently every 3 years, and primarily that's through a pap smear test. We are moving in the direction of HPV self-collection testing. So that'll be something that's new that we're rolling out this year. And it'll be a self-collection test, a swab essentially that you can do at home and mail your test kit to the laboratory, or you can do it at a clinic with a provider and support from a provider. And so this is something that we're rolling out in a pilot project right now in 2 regions, with provincial rollout expected potentially over the next couple of years. The big benefit, of course, is that you will not need necessarily a referral unless, of course, your test comes back positive. And you only have to do it every 5 years. And of course, there's all sorts of challenges and barriers, as we know, in more remote and rural communities of lack of providers, or just a familiarity of the one provider, which can make things somewhat uncomfortable or awkward at times. So that's cervical screening, 25 to 69 generally. Colon screening recommended every 2 years for those aged 50 to 74 and at average risk. So there are different pathways if you have a family history, of course, or if you've had other health complications in your history that would require you to be screened kind of outside of these guidelines. Again, talk to your provider, but general guidelines can be found at that link. Breast screening, we recommend ages 50 to 69. Again, talk to your provider, of course, because there are differing situations and recommendations depending on your family history. And lung screening being the 4th and brand new program. So we have not had a lung screening program up until, we still do not, it is being launched this April, but it will essentially be using CT scan capacity at existing health authorities. It will be managed by us at BC Cancer, and of course in partnership with the health authorities. And very important, I believe it's one of the first in Canada, and lung cancer deaths account for more deaths than cervical, colon, and breast combined. So, and in our communities, in First Nations communities, we're seeing lung cancer incidence on the rise, whereas in non-First Nations communities, we're seeing a decline or a plateauing. So there's a space, I think, where we need to do some work and support communities. Next slide. So let's go back to 2014. So back then I was with the BC Association of Aboriginal Friendship Centers, working with FNHA and BC Cancer and the Métis Nation. And we were trying to engage around cancer, engage communities, engage care providers. What was the experience like for Indigenous people in cancer care? There was no information. And so the very first thing we did was a survey. So as some of you may recall, FNHA put out a survey some time ago, again, 2013, 2014, as kind of the first kind of engagement around cancer, at least that we were aware of, with communities, trying to get a sense about what the experience was for people. And what we found was that more engagement needed to happen. The stories we heard were heartbreaking. And so we talked amongst ourselves and with BC Cancer and decided that we needed a strategy. There was nothing in this space to support Indigenous people, and we needed a strategy. And we had all of the partners at the table. And so based on the information we got from the survey, we decided we would do more engagement and then use that information to develop a strategy. And so you see in these boxes here kind of where our engagement points were. Obviously, the most important, First Nations people diagnosed with cancer, then friends and family who have First Nations people diagnosed with cancer. We know that they are primarily the ones supporting individuals when they're diagnosed, they get a diagnosis. Healthcare providers, of course, and then cancer care organizations, other First Nations organizations, and First Nations communities. One of the other things we did in this space was we implemented a data linkage project using the First Nations client file. So this would have occurred, I believe, in around 2016, 2017, maybe a bit earlier, with the paper actually being published here in 2017, which was just before I started. And so what we found out from the paper was that First Nations people are experiencing higher incidence of colorectal and cervical cancers, are less likely to survive a diagnosis, and we don't have any screening information. So essentially what we also found out was around lung screening, was what I mentioned earlier, was that we're seeing a decline or a plateauing of lung cancer incidence amongst non-First Nations people, whereas we're seeing an increase amongst First Nations people. So we're in the middle of a second data linkage project right now, which we will, this information here through this surveillance study only gave us information from 1993 to 2010. The next data linkage project that we're in right now will give us incidence, survival, mortality, and screening participation information right up to 2018. So we're working with the First Nations Health Authority and our data and analytics team at BC Cancer, as well as a specific Métis piece as well. But we're right in the middle of the second linkage project. We hope to have the data analyzed sometime this year, and then working with the FNHA on the different types of mediums and communication tools by which we can, provide access to this information for communities, for healthcare providers, for planners, whoever may need it to do that work. So again, I spoke to incidents, the first paper. Again, the caveat I would put on some of this information is it really only applies to status First Nations, because that's how the client file was developed. So it does not apply to non-status, and of course does not apply to Métis peoples either. So with that caveat, it still provides us very good insight into what we're seeing right now amongst communities. And that's that colorectal cancer incidence rates are observed to be higher, significantly higher amongst First Nations men and women compared to non-First Nations men and women. Cervical cancer incidence rates, again, significantly higher amongst First Nations women compared to non-First Nations women. Lung cancer. So rates increasing for First Nations people were plateauing or decreasing amongst the non-First Nations population. Breast cancer, most commonly diagnosed cancer amongst First Nations women. At this point, no difference observed in incidence rates. But again, that will only give us data up to 2010. Once we get this updated data, we'll see if that's still the trend or not. But very interesting nonetheless. Prostate cancer incidence rates significantly lower in First Nations men compared to non-First Nations men. Now, these numbers tell a bit of a story, but there's a lot underneath these numbers that we don't know. And so we don't know necessarily, we have some assumptions about kind of the behavioral aspects that kind of go underneath these numbers. But until we until we start engaging communities, survivors, patients, and families, we're really not going to know what these numbers tell. Survival. So we saw poorer survival rates amongst First Nations people diagnosed with cancer in 10 of 15 different cancer sites examined amongst women, and 10 of 12 cancer sites examined in men. So again, poorer survival, I mean, it could be a combination of a number of things. Not receiving a timely diagnosis, I think, is absolutely one of them, and it was certainly my situation. I did not go in until I was writhing in pain, did not have a healthcare provider at the time, and it was really the third time I went to the health clinic where I was referred to a specialist. So I think that is not as uncommon as we might think. I think that's probably the situation lots of our folks are facing. So that's a challenge. Access to screening programs. We know that folks in more rural and remote communities have access to healthcare barriers. So that's not new. And poor access to timely cancer treatments. Not getting, we know that people in the north, often it takes them weeks or months to get an appointment. Often they have to travel. So we need to break down some of those geographic barriers and start supporting folks where they're at. So again, as I mentioned, the data only pertains to First Nations with status just because of the limitations of the client file, although I still think the data is absolutely critical. And we're working with the FNHA and the Ministry of Health to access and analyze updated data, as I mentioned, right up to 2018, as well as screening participation for all three of our programs. So how did this inform the strategy? Well, we did a couple of things. So the survey, if you look at community stories and feedback, the survey was one of those pieces. We also held 2 engagement sessions in Prince George and Vancouver, and I want to say it was 2016, 2017, although my memory might be a bit foggy. And we had patients, community members, providers come to those sessions. And we had a full day of facilitated storytelling, feedback, group sharing, and getting, essentially talking to people on the ground who are either involved in this work or people who have experienced cancer or a family member. The second piece that kind of informed the strategic priorities of the Indigenous cancer strategy was a surveillance paper. So right now we only have data for First Nations and of course status First Nations, but that was the very first surveillance paper that I know of, and I'm pretty sure has been done in BC for Indigenous people here. And again, we're working on a Métis specific data linkage project. But for now, we have some information around First Nations cancer incidence and survival. And we will have more sometime later this year, updated information and screening participation for each of our programs. And what that essentially does is it gives us information on a regional basis, maybe even sub-regional, where we're then able to perhaps target some of our supports. And so that's what I'm most excited about. And so for instance, if we see in North Island here that colorectal screening is significantly lower amongst First Nations than non-First Nations, we can send some of our folks up there. I'd be willing to go up there. Our patient navigator can go up and start engaging with communities and talking about it, and talking with providers about why folks aren't accessing existing screening services and trying to educate them. So it's a lot about connecting the dots, I find. We do have some great resources and assets out there, but people just don't know about them, including my colleagues here at BC Cancer. So it's really it's a number of things. A part of it is research, a part of it is connecting people to the right resources and being aware of them. And so I think the third kind of driver in the strategic priorities is really the capacity of our partners. So the capacity of FNHA, capacity of the BC Association of Friendship Centers, and the capacity of Métis Nation BC to contribute to implementing the strategic priorities. So those 3 drivers are really what inform the strategy, and we continue to work with our 3 partners to implement the strategy. Many of you have probably seen this. The strategy itself launched in 2018, inclusive of Métis, First Nations, status, non-status, on, off reserve. If you're Indigenous in BC, then this is for you. And we've actually had lots of folks from outside of BC look at this as well, including some of the resources we've developed and kind of taken it on as their own too, or at least borrowed it. So we're very proud of that work, and we're in the middle of implementing the strategy now. So again, strategic priority areas, knowledge development, partnerships, screening, prevention, end of life, cultural safety, and survivorship. And of course, all underpinned by the sands of living well, health and wellness. In 2018, one of the things we also did was we held a patient mapping session. Some of you may have seen this. We held 3 different sessions with the Ministry of Health, and one of them was Indigenous specific. And so we worked with the FNHA to bring about 12 to 15 First Nations cancer survivors, patients, and their family members, whoever it was that was supporting them. We brought them all to Vancouver, and with the BC Patient Safety and Quality Council, we facilitated a full day session hearing from patients and their family members and survivors. Except one of the things we did was we hired a graphic recorder, and we had them, as you can see, chart this out into a visual diagram of the journey. And so what you see here is the feedback we got that day from our patient partners and survivors. And we continue to use this patient map today to kind of inform not only our colleagues and care providers, but also to show communities what folks are saying. Our hope is that we'll continue to be able to do this sort of work, but perhaps do it at a more local or regional level. And so that's one of the objectives is to give voice to survivors and patients. So what are some of the other things we're doing implementing the strategy? Well, we're having our 3,500 employees complete the Sanyas Indigenous Cultural Safety Training. And so we've sent benchmarks each year, and we report out each year on how many people have completed the training. Right now, we're probably at around 25 to 30% of our employees at BC Cancer having completed the training. So some work to do, but it is a commitment. We're looking at the facilities. So the creation of culturally reflective spaces at cancer centers and creation of spiritual care spaces for ceremony, protocol, and family gatherings. Working with the FNHA on accessing updated First Nations cancer data through our data linkage projects. Developing tools for care providers that promote culturally safe screening. And we have a flip book that's around screening for our 3 screening programs, and we intend to continue to build on that. Improving the complaints processes for Indigenous patients and families. We do have a complaints process, and all the health authorities do, but it does not involve Indigenous people at this point, at least at PHSA it does not, and so that's one of the things we're trying to change. How do we support Indigenous patients when they need to file a complaint or want to file a complaint, and how do we ensure that it doesn't impact their care moving forward if they do? So lots of questions in that space. We do have patient navigators coming on, which I'm going to touch on in a second. And we've hired 3 of them, 3 Indigenous patient navigators so far. And they are working out of Vancouver, Kelowna, and Prince George. And we have postings out right now for 3 more for Abbotsford, Surrey, and Victoria. And our hope is that we will have more than 1 patient navigator per cancer center moving forward, because outreach and engagement, like we're doing virtually here, although hopefully at some point we'll be able to go into communities and support you directly. But outreach has to be a big part of the work we do. Relationship building has to be a big part of the work we do. What I've realized in my 3 years at BC Cancer is we're very insular. You know, we do not engage with people primarily until they're referred to us and they have a cancer diagnosis. So there's work we need to do with the health authorities, with communities, and lots of work internally that we need to do. So I'm going to turn this slide over here to my manager, Ashley. The patient navigators all report directly to her, so she's in constant daily contact. So I will turn it over to our expert here.
Thanks, Warren. Yes, so as Jennifer and Warren mentioned, we currently have 3 Indigenous patient navigators out of the Kelowna, Prince George, and Vancouver Center, with 3 more postings up. So it's really exciting to be able to say that soon we will have 1 navigator per center, which means that when Indigenous patients enter the system, even if they start in Prince George, go to Vancouver, come back to Prince George, there will always be someone there to support them. And that's huge, and that's kind of gobsmacking for us to really think about. As Warren mentioned, a lot of the work that they're going to be doing is navigational support and resource connection. So not just resources for the patients, but as well connecting clinicians to those resources that already exist within the centers, but as well as in community. So when Indigenous patients go back to community, they have the resources and supports that they need. So whether that be home care supports, cleaning, transportation, things like that. So we're very excited about that. Obviously, a big part is going to be connecting patients to spiritual care, cultural supports, whether that be in-house or within the community. That's going to be determined just by patient need and what's available, obviously. Another piece, as Warren mentioned, is the complaints process. The interesting thing here is that because we have the ability to sit down and really connect with the patient and discuss with them, we can help them decide if they want to take that all the way up through the patient care quality office, or if they would prefer to sit down with that clinician and the center and just have a sharing circle, discuss what happened, and go from that angle. Without that navigator, that option may not have been available, because it really helps empower that patient to know exactly what their rights are and what they can do moving forward. Plus, they've got that, that advocacy piece to support them. We are in the process of finalizing our referral form and our referral process. So once that form is finalized, we'll be putting it up on our website, and people can just download it. They can send it to me, they can send it to their local IPN. Barring that, you can just call me, you can call Warren, you can call anybody, and we'll happily connect a patient to a navigator. The patient can call us. Really, any door is the right door for our department. So eager to connect. Did I miss anything, Warren?
No, I think that's great.
Awesome, thank you.
Okay, thank you. Computer's a bit slow here on changing slides. There we go. Okay, so back to the research and surveillance piece. So I mentioned the first data linkage project that we undertook that gave us some insight into incident survival and mortality for First Nations people specifically. We're now on our second data linkage project, which will give us the updated information, but we'll also link the First Nations client file with our 3 screening databases, which we have never done before, which is going to be very interesting. And so we're talking with, and so a lot of this work has been guided by the First Nations Health Authority Chair for Cancer and Wellness. And so that's Dr. Nadine Caron. One of the objectives of the cancer strategy was establishing a chair for First Nations Cancer and Wellness at UBC. And so that is Dr. Nadine Caron. It's a 10-year term. She has an advisory committee comprised of leaders from across First Nations communities and FNHA, as well as BC Cancer. And so we have been guiding that work to some extent, primarily done by First Nations leadership. But the 3 kind of aspects or papers, we're calling them products, if you will. The first one we're going to look at is screening coverage. So that'll be wait times, that'll be time to resolve abnormal screens, it'll be retention, the whole gamut for each of our programs. The second paper, because we know that First Nations are seeing higher incidence of colorectal cancer, we want to focus specifically on that. Cervical is another one that we're probably going to look at as well at some point here, but we know that colorectal is impacting both men and women. And so we want to focus and kind of peel the layers back a little bit on that. And I think the third product we're talking about is kind of a focus on updated incidence and survival data, because we will have data up to 2018 this time. So those are the 3 products, if you will, that the advisory committee under Dr. Caron have been talking about. And we're right in the middle of very first screening program. So we're talking about breast screening first, and then we'll go through each of the programs. But this process will probably take us, I mean, it's tough to say in the environment we're in, but I would expect it's going to be at least up to 6 months probably to complete all of this work. The amount of data we have back from all those years is significant and does take some time to get through, and you want to do it right, of course, as well. So, but nonetheless, we will get that information at some point, and I think it's going to be very powerful in terms of the ability for us to plan and to advocate for more support, and also for communities as well. So again, just talk about the advisory committee where we have leadership from BC Cancer and FNHA and UBC there supporting Dr. Caron. And these data linkage projects are a part of her data and analytics plan, along with a few other projects. Okay, great. Well, I'm going to turn it over to Kayla now. She's inputted a whole bunch of great resources here. So maybe I'll turn it over to Kayla to talk about them.
Thanks, Warren. Thanks, everybody. And I was just looking at the chat and just wanted to say thanks for sharing your experience, Adele, and I'm glad that you had a positive experience with your NP and your recovery. Okay, so I had just pulled together a number of different resources just to share about what is on FNHA's website and other places that might be helpful for everyone in your work. So Warren, we can just go to the next slide, if that's okay.
My computer's super slow, so just bear with me.
Thank you. Yeah, so just wanted to flag that we do have a cancer awareness webpage on FNHA's site, and we have a lot of the existing resources around cancer there. We are working on updating it, so you know, check back over time as we are refreshing it. I wanted to flag a screening information chart that we have that does give kind of that high level information about recommendations for different types of screenings, inclusive of cancer screenings, but also different things like bone density or various immunizations that could be helpful. We have a Living with Cancer booklet that is primarily for individuals with a cancer diagnosis, but also for family members or caregivers, and offers a lot of great prompts or questions to consider asking your providers to help with that kind of navigation and decision-making process. And then also just wanted to highlight that in 2018, there was a session around cancer and personal stories about experiences, as well as information about cancer screening, and that is available via YouTube. I found it really engaging and could be helpful if you know, a local workshop was hosted. The clips from that session are really helpful. The next slide would be great. One of our doctors within the Office of the Chief Medical Officer team has done a number of posts around primarily cervical cancer and breast cancer prevention work. And there are a number of blog posts done by Dr. Anjali Malhotra with the FNHA, and she will be doing some upcoming training with mammography and colposcopy providers this spring, which is great. And just also wanted to give the links to some of the kind of cancer data work that Warren was describing around the data linkage. We do have a community resource that gives a summary of that data, and that's the kind of light green colored picture document that's there on the slide currently. Next slide would be great. Yeah, just from more of a prevention and wellness support perspective, I thought I'd share a few resources that we have. So one, FNHA does have a couple of sessions of wellness grants every year. Typically it's in the summer and the winter. In the summer, it's focused on National Aboriginal and Indigenous Day. And in the winter, it's a broader wellness grant. So you could apply as a community for grant funding to do wellness work. Some examples could be, you know, women's or men's wellness inclusive of cancer screening information, or healthy living and chronic disease management, or things like that. I think there's a number of examples that are shared online. And the grants are fairly small, like in terms of money, but it's an opportunity to do some community driven work. And then these are just some examples of resources that we have online around healthy living. The daily organizer is just around health and wellness goal setting. There are print copies. You could email resources at fnha.ca if you'd like print copies. And then we've got some canning guide information and traditional food fact sheets too, which are both really great. And I just thought as well, you know, I think finding out about a diagnosis and going through your treatment and recovery is like, can be a mentally, emotionally, spiritually exhausting process. And so the availability of mental health supports, I think, is really important. And so just wanted to flag, if you do have First Nations health benefits coverage, we do have a list of mental health providers that are registered with the health benefits program to look at in terms of a connection point. And then as well, the other link is to broader you know, partners who FNHA has compiled in a list with different 1-800 numbers or websites and connections. A lot of these connection points offer culturally grounded supports. Environmental contaminants program I wanted to raise, it's if you and your community have a concern about a particular environmental exposure that you'd like to do some research on and explore, there is funding in a program to apply for through FNHA and our environmental health team. So I put that link there in case that's of interest. And then as well, in terms of broader wellness planning, advanced care planning for if you are ill or need support in end of life, or when you're not in a good capacity to make decisions, then it's a resource to do that kind of planning as well that's in relation to health and wellness. And we have regional respecting tobacco coordinators within each of the 5 regional teams. And we've got a number of resources online around reducing or quitting commercial tobacco use, as well as acknowledging the traditional and cultural uses of the tobacco plant. Wanted to flag those, as well as to say that we are working with the Canadian Cancer Society in developing an Indigenous specific quit service. And it's in the early stages, and we would be really grateful if anybody is interested in informing the work in terms of what would be most helpful. Yeah, if anybody would like to volunteer their time or input or thoughts, then if you could email respectingtobacco@fnha.ca. We're in the beginning stages of developing that service. And also I just wanted to say we are looking at refreshing a lot of our existing resources, making new additions, and maybe some new tools and resources too. So that work is currently ongoing, and it will come up on our website as they're finished. And I also just wanted to highlight a few existing resources with partners. In particular, Cancer Care Ontario has done a lot of work specific to cancer information resources for First Nations, Métis, and Inuit people. And so just wanted to put links to these in case they were helpful. There's some, 101, what is cancer, and talking about screening and what that looks like, as well as a guy's story around both accessing traditional and cultural healing services as a part of his cancer treatment. Yeah, I just wanted to highlight those resources too. And our partners at iSpark, Indigenous Sport, Physical Activity and Recreation Council, have a YouTube series, Food is Medicine, as well as they've recently put forward some resources around health and wellness specific to things like blood pressure, cholesterol, diabetes, mental health, and they're one-pagers. Put the link up there for that, as well as they've done some work in support of physical literacy, specifically with children and youth in school settings, that as well, just have put that link there. So thanks again for inviting me to be a part of this presentation. And I just wanted to share a number of different contexts, recognizing different people and different teams within FNHA can support in specific ways. So we've got our nursing practice support team around chronic conditions and serious illness, and our OCMO team that typically does like more public communications, information sharing, the quality care and safety office, our regional tobacco coordinators, wellness promotion supports, our environmental health team. And if you have any questions for me, then I put my own email right at the bottom there. Thank you.
Great, thank you, Kayla. Appreciate that. And our last slide here is just our contact information for our team. So myself there, my manager Ashley. We have our 3 current Indigenous patient navigators and their contact information there. And we have 3 roles that are posted that we're hoping to hire over the next month and a half. And so feel free to reach out to any of them with any questions about anything cancer related, any support we can provide. There's lots happening. There's lots happening, and direct patient support is our #1 priority. So if, you know, even before you have your first appointment, if a community member has an appointment at one of the cancer centers, we would recommend connecting with the patient navigator before you even have your first appointment. I wish I would have had that when I was diagnosed in 2009, but I think it's going to make the experience a little less scary. You'll have somebody to be your point of contact throughout your experience. If you're treated, you know, with disrespect, or the care is deemed as unsafe by you or the community member, we have somebody there who will advocate on your behalf, who will support you through the patient complaints process. We'll meet with the provider. We'll do everything on your behalf if you would like that. So we're really proud that it's been 3 years I've been advocating for these roles. So it's been a long time coming, and we're really happy with the team we've built so far, but there's more work to do, a lot more work to do. Part of what I'm really hoping for out of this relationship, as I'll call it, is other opportunities. We've given you kind of a broad overview today of cancer care and what we're doing in terms of the Indigenous cancer strategy. We've done some direct community engagement as well. So we've had a couple of virtual sessions, one with the Tla'amin First Nation. So if anybody from Tla'amin sees this, thank you for having us. We went up during breast screening month in October and did a virtual event, if you will, 2.5 hours of presentations, door prizes. Yeah, it was just a good overall education and awareness session that was made as fun as could be. We'd like to continue to do more of that. We realize we're in a different environment today than we were a few years ago. And maybe we're not doing in-person engagement at this point, but we've sort of got the technology piece figured out and are happy to provide these sorts of direct virtual sessions with communities based on any cancer-related topic you want to talk about or know about. You know, there's a lot we could talk about any one of our screening programs in length, like we did in Tla'amin. So I think there's lots of opportunity for my team and for our colleagues at BC Cancer to engage communities, and that's what I'm hoping comes out of this is relationship building. I think if we're able to do that properly, then community members will receive better care. I firmly believe that, and so that's our mission. And so with that, I guess I'll close our presentation and turn it back over to Jennifer and the team if there are any questions or any discussion.
Thank you. What a wonderful presentation. And I think that's coming at a perfect time because we need to have more discussion on cancer and healthy lifestyles. So is there any questions from our health directors? I just want to share that before everyone came on, I shared with Warren and Ashley about a member that passed away just recently. I've been working in Stamanis for 2 years, and I really gravitated to this young fella. And I was sharing with him, well, I didn't share that I have 2 daughters, but I don't have a son, but I have 2 son-in-laws I'm really happy with. However, this young fella, I really gravitated. He just had the warmest smile. And every time he came to the health center, I was always there to say hi to him. And little did I know, for about the past 10 years, he was having some issues that I was not aware of until he became really sick and landed in the hospital. It wasn't until they put him on palliative care that I was informed that he was bleeding every time he urinated, and I was not aware of that because I would have made him go to seek medical attention long before, because you know I was in at Stamenis for 2 years, and it just breaks my heart because he passed within about a month after getting into the hospital. And then again, you know, as a registered nurse and working in communities for the past 22 years, I just want to say that, you know, I've dealt with a lot of members who passed away from cancer. A lot of our family members don't want to tell other family members. They just want to keep it secret. And then the devastation that I see once they pass on, after the family realizes they passed up on opportunities for medical care, just because of maybe the lack of knowledge, maybe maybe they're really afraid to move forward with the cancer treatments. So anyway, is there just putting that out there? I know we have a lot to share, and we can learn from one another. So I feel like one of the things I heard from Stamenis recently is that they would like to have, you know, and I'm thinking, why don't we do hosting some lunch and learns? Let's talk about cancer, more making it a topic that we're all comfortable with. So anyway, that's my 2 cents. Is there any comments for Ashley, Warren, or Kyla?
Yes, I think Kaloa has her hand up.
I don't really have a comment. I'm really happy that I was on this meeting today, and I think one of the things for me in Stalo territory, there is some real issues around environmental, and there's certain communities that have a higher rate of cancer, and then there's certain communities that have a higher rate of lupus. It'd be interesting to really dig in and do an environmental kind of look at this. So I was really happy to see that component. I too am a colorectal cancer survivor, and the nurse practitioner at our client that I'm a patient at was on me every 18 months to be screened. And I really want to lift my hands to her, because she really supported me in getting that screening. And my diagnosis was a very aggressive type of cancer. And it just so happened that during the time I was on a ketogenic diet. And so I was really reduced the carb and sugar intake. It happened all at the same time of COVID-19 when that hit. I was screened in February. I was scheduled for a colonoscopy in March, and that got canceled until June. And when it was revealed, it was a very aggressive cancer. And I actually owe it to both my nurse practitioner and the fact that I was on a ketogenic diet where I was restricting the sugar intake. Had the surgery, they removed 7 inches of my colon, and there were no markers. They tested 12 of the lymph nodes that were in what they took out, and none of them had cancer in them. So I was very grateful, very grateful. But it's highly emotional. Like the whole journey you don't know about it until you go through it. And there is a significant mental health component to it. So, you know, I'd be interested. I'm actually going to be retiring soon, but I'd be interested in sitting in and being a part of whatever time I have left. I'm going to be done by July. So, but yeah, thanks for letting me share.
Thank you for sharing. Wonderful.
Yeah, if I could just chime in, thank you so much for sharing your story, and congratulations. It's a difficult experience, as you know, and I felt the same way. And I tell people that as well, that although it's a physical battle, there is a point where it becomes an emotional battle. because you go through day in and day out of the same thing and perceivably no end in sight. For me, it was about 9 months, but it's challenging, you know. And so how do you keep yourself in the frame of mind to be able to keep going? Me, I found that, you know, I knew some people on the island here, and so ceremony was a big thing for me. I was also able to access some medicines here from one of the territories up island that was given to me by one of the traditional people up there. And so I think, you know, those sorts of things are the things that we can support, and by building relationships with people in the community. So access to spiritual care, for instance, we want to be able to build relationships with some of those spiritual care providers where we can compensate them to support patients where they're comfortable doing so and where it's appropriate. But I want to get back to your point about the contaminants, Kaloa, because that's a very good point and an issue that we are looking at. And I'll tell you that there are a few communities who have reached out to us with that concern, that they're seeing higher incidence of cancer. Don't know for sure whether it's related to a contaminant, but it very well could be. We've only done one study so far, and so we do these things called cluster studies. And so we take postal codes. It's unfortunately the best determinant we have right now to determine geographic area. And we look at cancer incidence within that geographic area, and then we compare with what we're seeing across the rest of the province. So is what we're seeing in this community different, or is it kind of on par with what we're seeing across the rest of the province? So we've only done that in one First Nations community to date, and it's in Vancouver coastal area. And it turned out that what we were seeing for incidents was actually on par with what we're seeing amongst the rest of the province. Now that doesn't mean that everything's great. We're seeing higher incidence of cancer, but what it might suggest is that, you know, there's no external factors perhaps influencing that higher incidence of cancer, because we're seeing that elsewhere amongst the general population. We have another community who's raised the same interest. They do have a contaminant that is close by, and so we're working with them now, as well as the medical health officer for Island Health, to kind of figure out how we support the community to kind of understand if indeed the contaminant is what's causing the cancer. And so we have this community investigative process at BC Cancer, and I'll follow up with a link to it. It's essentially a small form. You got to fill out 2 pages, just community information. And then once we get that form, we look at it, we'll do a bit of a risk assessment, and then kind of determine with the community what are the next steps. And so that's the existing process we have now. And I'll follow up with a link to the web page and the form, but I expect that we're going to see more of that. And so I'm talking already with our scientific director of the Cancer Registry about how we support communities who bring those sorts of concerns to us, and making sure we have the capacity to respond, right? The last thing I would want to do is, you know, tell communities that we have a process where we can support them if they have a concern about carcinogenic exposure causing cancer, and then not have the capacity to respond. So it's absolutely a part of the work we're doing. The question will be is, you know, how does that capacity get built to sort through those issues and work with communities in a good way? And so absolutely it's on the radar. So that is that piece, but I also want to speak to your retirement and your support. We would love for you to support our patient experience work. You know, I mentioned we did a patient mapping session back in 2018 where we brought 12 to 15 First Nations cancer survivors and their support people. And so we want to do that patient experience work in the regions, or more locally even. And so what that looks like, we're still kind of figuring that out. We do have patient navigators working in the regions now, and our hope is that they will be able to facilitate some of that work. And then we develop a bit of a survivorship network that we can call on folks to give exactly what you did, Kaloa, was just share your story, your experience for others to be able to hear, to understand, and to help them make informed decisions. So anyway, I really appreciate you sharing with us today. And if you're open to it, we'd love to take your contact information, and we get to the point where we're doing the patient experience work, we'd love to add you and yeah, have your expertise. Awesome. Okay, any other questions or comments?
I have a comment. I just wanted to say, you know, those beautiful cancer books that you guys had on display up there. Now, do patients get those once they enter the cancer screening session? I'm just curious about that process. How do you guys distribute that type of book?
Yeah, are you referring to the very nice survivorship booklets for the patients? Yes, actually, we were just talking about that with Kayla the other day. So I think we're looking at doing a print, so a reprint. We did a first round, and yes, they do. So we have copies up at each of the cancer centers. Whoever self-identifies as Indigenous and would like one of those books, we have First Nations and Métis specific ones. They're absolutely given out. And beyond that too, I mean, I think our hope is that, we're giving these out more broadly, not maybe just to patients specifically, but there's lots of great information for family members and care providers, community members, health planners. So maybe I'll let Kayla speak to that a little bit, because I think she's kind of organizing how this is all getting done. So I want to put words in her mouth.
Thanks, Marin. Yeah. So we're just doing like looking at creating a new edition of the Living with Cancer booklet. And we're currently looking at printing and number of copies and distribution. So still to be determined, but we're definitely thinking about like generally primary care provider clinics and whether or not there's a possibility to mail out more broadly and or within each of the regions, how to distribute. And of course, we always have our standing resources at FNHA.ca email in terms of requests for print copies. So that's a way too for any of our resources. If you have an inquiry about whether or not we have print copies to mail, then that would be a great email to use.
Thanks, Kyla, because I also, just want to acknowledge I have a good friend that's just surviving breast cancer. She's just finishing her radiation, I believe it is. And then I have a cousin, the same process. And I really want to know if they were offered those books. And really, do people really self-identify as Indigenous? Because, we all have our issues about, what's going to happen if I self-identify, right? So, but I just feel like that book is a great and would be a great resource for not only the survivor, but for family and friends of the, people going through the process. So that's just my 2 cents. Thank you.
Great points, Jennifer. So yes, every person who self-identifies and wants one of those booklets should get one. There shouldn't be any limitations on that. We have the numbers and we have access to them, so that shouldn't be a limitation. The limitation is really, does the care provider know about the booklet and offer it to the patient, right? I mean, we have 3 Indigenous patient navigators now who are familiar with the resource, and we'll hand them out as necessary. But in 3 of our centers, we don't have those individuals yet. We've got the postings out, but we haven't hired them yet. So in those other 3 centers, it's really, we have to rely on our colleagues to know about those resources and to hand them out. So I think there's limitations until we get people on the ground, but I expect that as soon as we have a patient navigator in each cancer center, we're going to see utilization of those booklets go up, because people are going to self-identify. And I mean, that's a very interesting issue you raise, and it's something we've been looking at. I think we know for a fact that lots of our folks don't self-identify for a bunch of reasons, but it's so important that they do. And for the first biggest piece is that, in terms of the cancer strategy, the information that we get back from the clients and patients that we're serving, whether they're Métis, whether they're First Nation status, non-status, like all that it's good information for us to have. But really, we want to be able to tailor our services as well. So right now we have Indigenous patient navigators, but if we have more people self-identifying and we get a bigger picture of the patients that we're serving, then there's more specific things that we can do. So it's really about trying to make sure that, we know the client base or patient base that we're serving, and that we're making sure that our services and our care plans are tailored as such to meet the needs of each community member. And so it is important that they self-identify. We understand the reasons why folks don't. That's why I'm hoping that with the hiring of these new patient navigators, they can support people through a way to safely self-identify, I guess I would say. And so that's why I hope that, as soon as any community member is given a cancer diagnosis and before they have their first meeting at the cancer center, I would love for them to contact our patient navigator so they can get a sense about what to expect. The things that they'll be asked at intake, any support they might need, all of that. So anyway, that's kind of addressing a couple points there, but yeah, you raise a good issue around self-identification. It is something that we're looking at. We've created resources for our non-Indigenous colleagues who are asking those questions. As you can imagine, asking identity questions to an Indigenous person by a non-Indigenous person can come with its challenges if it's not asked appropriately, and we're already seeing that, right? We're already seeing those challenges. So it's an exercise in patience and training, essentially.
Thank you. And so Kyla, one of the things that I would like to recommend is, you know, how can we get these into First Nations communities, like to really promote being, you know, the benefits of self-identifying, because you're going to be entitled to extra resources. Because I was not aware of these resources, and I would like to reach out to my 2 friends that are dealing with cancer right now to see if they were offered that, and they're both on the island. So, and you know, just how can I spread the word? Like, even for me, having a couple of those books in the Stamanas Health Center would be a benefit, right? So just putting that on the table. Like, I don't want to have 200 books, but, you know, having 5, and then if I need to have 5 more type of thing, that's how I'm looking at that. Thank you. It's a great discussion. And I feel like I'm hogging the platform here. Does any of our other health directors have any comments?
I just wanted to respond, Jennifer, to say that definitely is part of our distribution planning with the new print that is being planned. There will be kits sent to each community with not just the Living with Cancer booklet, but other materials. And there will be an introductory letter that will kind of give a broad overview of what's all within that package. So for sure, have the intention of sending out some print copies directly to communities as well as friendship centers too.
The other thing I'll put out here, since I've got the time, for folks who are seeing this as a recorded version, we'd be more than happy to set up individual sessions as well with your community or with your health clinic staff, whatever the case may be. Yeah, we'd be happy to engage directly and look at specific topics too. For instance, if colorectal cancer is you're seeing higher incidence in your community, or you have a number of members who are experiencing it and have went through it, and you want to know more, we'd be happy to bring not just our own colleagues and our experts, but we'd be happy as well to come and talk to you directly, i.e. virtually, should you wish it.
Great. I think what I'll do is stop recording now. And then if nobody has any other questions, and we'll have Jennifer close the meeting for us.